and family sizes remained high in Kenya up to the late 70s. It is only is as a result of that the NCPD was established in the early 1980s to be able to overcome those challenges that had been experienced in the implementation of the area effort in the 60s and 70s. And what NCPD was supposed to do, I think we all know about it, the coordination and formulation and implementation of population policies. And you know that the very first inaugural leaders conference was held in 1982. And that is the one that adopted the very first national population policy that we had, a sessional paper number 4 of 1984 on population policy guidelines. And that is the one that set the framework for this other subsequent review of policies that you've seen, I think in the 2000 and 2010 or 2012, to be able to accommodate the emerging issues at national and international levels. So the sessional paper number 1 of 2000 and third of number 3 of 2012. We are all familiar with that and won't go into the details. Now, it is this approach, the establishment of the National Council, that actually we started seeing some change, because at the end of the 1980s, we were able to see
So, Prof, 1 more minute, then you can end.
1 more minute. All right. All right, then, Chair, we are able to see. Let me utilize my 1 minute. We are able to see those changes that we started seeing the decline in fertility started in the late 1980s, and which has continued up to date now. But in spite of that progress, still many challenges still remain as far as the population growth and fertility are concerned. And one is that population growth is still high. Fertility is still high, although we have made some progress. We reduced it to below 4 births per woman. But then the contraceptive use has increased, but it's not as high. And then also that a substantial proportion of women who will need family planning services are not using them. And there are also some wide variations. The national level data that we have on population growth, on fertility, on contraceptive use, has actually masked what we have already had, the major disparities between the regions in different counties or different regions in the country. Now, I do not want to go into that, but I want to indicate how can we deal with those differences that we note. Okay, and I would like to pick some of the studies that we have done at the Institute. They have analyzed and shown, for example, we know that, for example, in the central region, the demographic situation is a little favorable. The fertility level is declining to almost levels that we witness in the Western world. But when you go to the northern region of Kenya, you find that the demographic situation there is what we had in the other part 30 years ago, now, or nearly 40 years ago. So some of the studies, what have they been able to show us? And this is what I would like to share with you. And I've picked recent studies that have been done in looking at region, counties in central region and in northeastern. And we note what would explain, for example, if you probably have the data, the fertility rate in central region is about less than 3 births per woman. In northern region is about 8 births per woman. What explains those differences, and how can we be able to deal with them? Give you some quick information here. Chair, if you can just give me 1 minute.
Half a minute, Prof.
Half a minute. Okay. All right. Now, when you look at Madeira and Nyeri, you find that the level of contraceptive use, modern use of contraception in Nyeri, is 67% among married women. In Madeira, it's only 2%. And that tells you that that is the main reason why fertility is low in Central, because of the higher contraceptive use, while contraceptive use and fertility is high in Madeira because of the low contraceptive use. But what brings about the low contraceptive use? We do have studies which tell us why that is the case. And I would like to say that as I conclude, that we know that the lower socioeconomic situation in northern region partly contributes to the lower level of use of contraception in those regions. And therefore, we can be able to enhance the use of contraception in those regions by specifically doing a few things which these studies show: the promotion of the education of the woman, reduction in child mortality, and creating awareness of, to overcome some of the cultural barriers. So cultural barriers, lack of education for the woman, and the high mortality is what is bringing these differences. So, so it is in the interest of us to be able to work together, NCTD and the national and the counties, to be able to try to overcome and handle those challenges.
Thank you.
And I'm proposing that we make use of research resources much more than we have been able to use other research findings to be able to deal with this. And we can do much more. And thank you, Chair. And sorry
thank you, Prof. Thank you for highlighting these issues and comparing counties and indicating some explanation and the historical background of the development of population policy and family planning policy in Kenya. You are a guru in this, and we appreciate it. We want to say that sorry, we were not able to show the slides of Professor. And so, James, we would like you to indicate what is the challenge. James? Hello? What is the hitch? The slides are not coming along. And so we invite Peter Gichangi to take on the floor. And we give you your 10 minutes. Use it efficiently.
Thank you, Chairman. And members, my apologies. Feel me, but I've managed. Can somebody show my slides?
Yes, James, you are my assistant, James Macharia.
Yes, can you see the sharing now?
Can you show the slide?
Something going
I don't.
on. Can you see me?
We have the PowerPoint.
Can you see
that's what I am seeing.
You see the slides?
No.
No.
Yes, we can see.
Can you get help?
No.
Can you get help?
Let me stop the sharing first, then I make it again.
Okay, Peter, you can start by introducing yourself. Take a minute to introduce yourself, and then you just start on.
Okay. Yes, thank you, Chair. And my apologies again. Professor Peter Gichangi is my name, obstetrician gynecologist and public health practitioner, currently Deputy Vice Chancellor Academic Research and Extension at the Technical University of Mombasa, and the Principal Investigator for the Performance Monitoring for Action project funded by Bill and Melinda Gates Foundation, where we cover 11 counties. So I will be able to draw my presentation from the experiences we have of women from 11 counties, as well as other documents which have been produced in this country. And so the title of my presentation is Need for Addressing Family Planning Concerns for Users and the Need for Domestic Financing. These are very, very important topics, one which touches on the people's well-being, but also touches on the people's pocket, particularly when you speak to domestic financing. So somewhere, I don't know whether you have, no, there's no slides. So I'll proceed. So
yeah, just proceed.
Right. So the outline of my presentation, unfortunately, you cannot see it. Kenya commitment regarding contraceptives. I choose contraceptives specifically because it's broader than family planning. Status, global, Africa, and Kenya. I'll look at the concerns in terms of accessibility, availability, service provision, readiness, as well as counseling, and say something about disparities. I'll look at the importance of addressing these concerns, importance of addressing domestic financing, and I shall conclude my presentation. When we get the slide, my slide number 3 is looking at the status of family planning or contraceptives. We know that there are 69 focus countries for family planning 2020. And by 2020, 320 million women of reproductive age were using contraceptives. But please note that in that same 69 countries, there are 945 million women of reproductive age. So it's not everybody who should be using family planning, and you can now contrast 320 million versus 942 million.
No, just continue.
Okay,
just continue.
I shall proceed. Thank you. So Kenya committed itself to increasing modern contraceptive prevalence rates from about 61% to about 66% by the year 2030. We are 9 years away from that target, but I think I would say nationally we are doing quite well. Now, we know that increase in CPR was also targeted among adolescents 15 to 19 years, where we are hoping to increase from 40 to 50% by 2020. We are already past 2020 and 55% by 2020. Importantly, reduce teenage pregnancies from 18% to about 12% by 2020, 10% by 2025. So this was anticipated to be achieved through increasing the national budget for family planning and services, specifically through having budget line dedicated to family planning. And we will see later on that this has happened to some extent, strengthening the private sector, including the for-profit. And this is an approach of total market approach. And this was considered important in terms of widening the reach and access for women of reproductive age in this. Next slide. Thank you. So if you look at the trends in contraceptive use in Kenya, we know that in 2014, we had demographic and health survey nationally for women of reproductive age who are married. The use of family planning was about 23%. PMA showed about 25%, but we see a gradual increase in use of family planning over time. The 3 lines you can see there, the green one is married women, the blue one is married and married sexually active, the red one is all women. And you see there have been an increase from about 41% to about 46% in terms of use of family planning by women of reproductive age. This data is from 11 counties where PMA is implemented, but I can tell you that the point estimates are very close to what is probably in the DHS. Next slide. And so what are some of the concerns among the users? And we notice that physical access is important. Are there medical facilities for people to be able to access? If you look at Kenya Master Health Facility List, nationally we have achieved a density of 2.2 per 10,000 of the population, with a normative target of 2 per 10,000 as per the WHO. Technically, we have achieved that. So one would say we do not construct new medical facilities. However, that is far from the truth, because we do know there are women who have to walk long distances before they can access these services. So a national point estimate is sometimes hides the disparities which you know they exist. Even at that time, as from the Kenya Harmonized Health Facility Assessment of 2019, we note that 14 counties were still below the target of 2 facilities per 10,000 of the population. The next concern is the health workforce. Do we have the necessary health workforce to provide other services, including family planning? And the answer is we are not yet there. We have about 15.6 health workers per 10,000, where the normative guide is 23 per 10,000 of the population. We take note that only about 6 counties had met that target, and this included Rakanithi, Nyeri, Uasin Gishu, and Nairobi, while majority of the others were below. So certainly we still have a challenge. There are other important areas we need to think about, myths and misconception, which we know can lead to failure to access, to use, and certainly that can lead to unintended pregnancies. Next slide, please. And here we share data from PMA, where we are showing stock out of different methods. And we see here, if you're looking at injectables, if you look at 2020, we had about 15% or so of facilities either stocked out at that moment or 3 months before. Certainly 7% of facilities are not having the commodities. One can say it's an improvement from 2019 to 2020. But the red bars, it signals that there's a stock out. If you look at implants, we see the same, that in 2019 and 2020, about 13% of facilities were stocked out at that moment, and another group 3 months before. Important to note is that of those stock out episodes, 70 were due to the fact that they are not received the commodities yet they had ordered. So that is something we need to think about when you're looking at what is the place of family planning in this country. Next. If you're looking at service, family planning service readiness, of course, the Kenya Harmonized Health Facility Assessment looked at different parameters, and indeed, we're probably doing well in terms of the necessary things. However, in terms of availability of the tracer items, only 83% had the tracer items in place. And we note that from PMA, if you're looking at preparedness of the facilities to insert implants, only about 70% had the trained personnel, materials required for insertion and removal. What about IUD, which is another important long-acting method? Only 61% nationally were having a trained person, materials required for insertion or removal of IUD. So clearly, there's need for us to look again at facility preparedness to be able to provide the required family planning. And certainly as a user, you are concerned, because if you go to a facility or a different location and you're going to use your product, then that is truly a serious concern. Next. And this slide is important. I wish the entire country was all dark green, because dark green is where you have over 80 to 100% facilities ready to provide family planning services. That should be the goal, but we do have a small pocket where it is about 40 to 60% of, and majority of the other, then you have about 60 to 80% being ready to provide family planning services. If you look at this map and look at the disparities in terms of use of family planning, there is quite some correlation here. Next slide. And here we are looking at method plus index, and this is data from PMA. Nationally, only about 44% received comprehensive counseling. And again, this is an important element for us to think when you're looking at the quality of services. Take note, about 37% of the persons were not told what to do about side effects, while 30% are not told that there are other methods of family planning. So we are talking about women having limited choice because they don't know they exist, or they're not being counseled. Next. And here we are looking at disparities in terms of wealth quintile. Q1 is the lowest wealth quintile, and Q5 is the highest wealth quintile. We see indeed there are disparities in terms of usage of family planning, and we also see changes in terms of unmet need for family planning. As you look at the bottom of the slide, you'll see the demand satisfied by modern method. If you're poor, your demand is only 65% met, while you have a rich one, it's somewhere between 79 and 81%. For
2 more minutes. 2 more minutes, Prof.
Yes, thank you, sir. You see the same trend. Next slide. And here we're looking at education as an important element. We can see no education, 27% usage, 47. Whether married or unmarried, the disparity is there. Next. And we see here a county which is relatively doing well. I should have said my presentation is not name and shame. Counties have different realities, and therefore the comparison here is not to say one is doing better than the other, is to show what is there on the ground. And we see that a country like Bungoma has quite a high percentage of the demand satisfied by modern method, where if you look at the county like West Pokot, is about 50% of the demand met by modern contraceptives. Next. And so why is domestic financing important? We know that if you're going to achieve universal health coverage and you're looking at the highest benefit cost ratio, then think about family planning. We know that family planning has many benefits, socio-economic benefits to families, societies, because women are more educated, there is increased earnings for the facility, at the family level, and this also reduce poverty. We know prevention is cheaper than treatment, and therefore, if you're looking at things you need to look at is consider family planning. For each dollar spent, you reap about $2.2 in terms of benefit by using family planning, and we know this saving is enormous, 6.9 billion if you add family planning to maternal and newborn interventions alone. So really, and there are groups talking about demographic dividend, and I'm sure this is going to be discussed in details in those meetings. But for us here, it is important just to appreciate how important family planning is and why then we need to pitch for domestic financing. Why? Currently, about 49% of the cost of family planning is met by donors as well as individuals. That's a huge cost, and particularly when you go to individuals, out-of-pocket expenditure. Next slide. And here we know why. If you look at what is the problem in terms of domestic financing, we know insufficient resources will limit access and usage. Over-reliance of donors creates barriers in terms of out-of-pocket and also increases equity. Donor funding is unpredictable, and we have seen two situations right now because we are middle income status, because we are expected to take up our bills. But we also know when HIV came to town, resources were diverted. We have not seen a lot of diversion from COVID-19, but certainly there are effects which are happening there. So increasing budget allocation in terms of family planning, increasing spending of the resources available, efficiency of use of resources, leveraging other sources will be important, because then we can have increased expenditure on family planning, increased share of expenditure from pooled funds, and we'll be able to reduce out of pocket, which a lot of time impoverish people. And therefore we can have increased availability, equity, access, and quality of family planning services being improved. Next.
Thank you. Summarize.
Yes, I'm going to summarize now. So if you look at the Kenya Health accounts of 2019, we see a lot of out-of-pocket expenditure, about that, the 3% of current health expenditure. Next. And so if you look at the current financing situation, we do have gaps in terms of the family planning, and we need to be able to close those gaps. Next. And so this is really to look at why do we need to think about budgeting as people are implementing programs. We need to understand the budget formulation, budget execution, budget monitoring, because only then we are able then to make sure that we can advocate accordingly. Next slide. And so inclusion of family planning is a key strategy for the national government as well as some national government. We know there's things which have now budget lines are available in some of the counties. We know budget has been spent. We have strengthened the private sector through the implementation of total market approach. We have documents which are now capturing that. Roadmaps are being developed to prioritize high impact intervention. And one of the high impact intervention is domestic financing. And certainly we are recognizing family planning in the Kenya Essential Package of Health, as well as insurance programs. Next.
Thank you. Last one.
And so the recommendation here, have a second, Chair. We need to prioritize intervention, addressing vulnerable people, budget allocation, looking at how do you operationalize what we have. Next. And to conclude that Kenya has the potential to deliver its family planning services to its population. And with that, I thank you all for listening and the opportunity. Back to you, Chair.
Thank you very much. Thank you very much, Prof, for very critical information. We know we have pushed you, but I'm happy the slides came up. The other early speakers were disadvantaged. So we thank you, and these slides will be shared. And we move quickly for the last speaker, and this is Dr. Dan from UNFPA. Are you there?
Yes, Prof, I'm there. And
yes,
you are
our last speaker. Yeah, yes, do it very fast because your world has been made easier. So let's see. Okay, start introducing yourself.
Yes, my name is Dan Okoro, working with UNFPA and obstetrician gynecologist previously with the Ministry of Health. Can we move on to the next slide, please? What is this? Next slide. Yes, so I think this has been covered by, there's something obstructing my screen.
No, I see nice ladies at the counter receiving service. Just go on.
All right, so the principle, okay, we can just jump this because in the interest of time, I'll just move on to the next slide. Yes. Yeah, we know the importance of controlling or managing fertility. And in Kenya, basically the population growth is largely influenced by the fertility, which in turn is also influenced by the education, the government policies. And what is important for us to know is that the terminology which we use, sometimes family planning used as a birth limitation. And this is what does not augur very well with the community. But rather we should look at it with the aspect of birth spacing, which addresses the health issues. I think we just move on to the next. I think this has been covered largely by previous speakers. And the challenges currently we have, inequity has been addressed by Professor Gichangi and the rest of the team. The engagement of the community has been very low, or utilization. The private sector we have suboptimally engaged. The issues of myths and misconceptions. The shortage, male factor of the power in terms of the asymmetry, the male dominance, teenage pregnancies, and the use of the contraceptives amongst those that population has been a major issue, even at the policy level. We move on to the next. Yes, so while we address this in terms of the policy recommendations, it's a decade of action where we accelerate the sustainable solutions and addressing the issues of poverty, the gender, climate change, and inequality. And we would like that to use family planning as a driver of sustainable development, engaging the policy makers and to view family planning as a driver towards the sustainable development, including the Vision 2030 for the national goal. Improve the coverage, work towards improving the coverage, including use of the community-based distribution of the community health workers and applying the community health strategy. The issue of the male involvement, this has always been running across. Quality of care, as has been mentioned we see discontinuation rates of the clients using family planning not cancelled well. Method mix and ensuring community security. This is quite key for us to ensure quality of care. Integration of family planning beyond even the health sector, looking at the manufacturing, looking at the agricultural sector, so that we don't just look at family planning just even with the health facilities, but even beyond. Sustainable domestic financing has been largely addressed even by Professor Gichangi. So, but importance that leadership role, the leadership of the national government and even at the county system is vital. Next. I think we're almost coming to the end. Yes. So we addressing gender imbalance family planning should not be just looked as a woman's issue, but it should be looked beyond just beyond the female factor, and looked at, as mentioned in the previous slide. A stronger partnership with the development partners and the stakeholders is quite key, that to alone, even as at a community level or even as a government, may not. So we need to engage the other providers or other support system available. Private sector, the total market approach, like those who are willing to buy, those who are willing to pay for the services should then have an enabling environment for them to access. This will also reduce the need for the government to procure the commodities. Strengthen the performance and accountability, adapting service delivery, even in matters of when we have crisis or including the pandemics or epidemics. Health insurance coverage, inclusion of the family planning within the UHC, engaging family policymakers like we are doing in the population conference on matters to do with family planning and during development, and innovation and technology for service delivery and data management, as Professor has given us during the PMA analysis that has been given. I think Professor been rushed, and I think this is the challenge that we have. Even
thank you. Thank you very much.
Right.
Thank you, Dan, for taking us through very quickly. Now, the panelists, we are being told that they are going to close the breakout sessions, but let me give it to the floor. If there is any quick question